I'm going to talk here around a typical critical care bed space. I'll just start and walk around the room. One of the first things you'll notice is the amount of space allocated to each patient. There are a number of reasons for that. It makes it easier for multiple people to be around the bed space at the same time. And that facilitates the ability to do procedures simultaneously. You may, for example, have one of the medical staff inserting lines, reviewing the patient, whilst nursing staff are drawing up drugs, attaching monitoring, and doing other interventions. But also the ability to reduce the lighting and make the room more comfortable. It is well recognised that delirium is very common in critical care patients, and if we can do things to reduce the risk of that, such as have a clock visible by the patient, which is behind you currently, have boards of information which have the date and time and the name of the nurse looking after you on them, and also the ability to screen off the bed space from other parts of the unit, then these are all things, non-pharmacological interventions that may reduce the complications of delirium. Moving more specifically on to the equipment around about the bed space, you've got a significant amount of power points to supply power to potentially a large number of devices beyond what you can see here. As a basis, you will find monitoring, which is over to the right hand side here. That's that Philips screen. That's real-time monitoring that will be connected to the patient, and there are a number of modules that can be attached to this bay to the immediate left as you look at it. We'll go more specifically into some of those in a few minutes. Other bits of equipment are the ventilator, which is at the head of the bed in this bed space, but does move around in other bed spaces. It can sometimes be found on one of these pendants hanging beside the bed, or can be mobile as is in this situation. The ventilators do not all look exactly like that. There are various brands and various models within each brand, but they all do a similar role in terms of facilitating ventilation and oxygenation. Moving to the left further still, we have a stack of infusion devices. Although these all look very similar, the bottom four are for syringe driver, syringe pumps. So they are typically used for infusions of some of the sedation medication, like fentanyl, midazolam, but also for replacing electrolytes and boluses of drugs that can be given over a shorter period of time. Examples would be magnesium, potassium, some of the antibiotics. Immediately above them you have three other broad devices which are used to deliver infusions, volumetric infusions. They would be typically attached to a bag of fluid or medication hanging here, and these control the rates. They're similar to other volumetric devices used in other parts of the hospital, just again a different brand and model. Moving around slightly further still, there's a set of drawers, some PPE found in the bed space, other PPE is just round the corner. And each of these drawers are set up to have specific types of equipment. So in the top drawer you'll find some airway related equipment. Anything beyond that is kept in a separate airway trolley, which is located in two separate areas in Ward 201 critical care and in one in 106. Immediately below that there is a drawer with essentially feeding related equipment. So one of the other infusions or one of the other volumetric devices that you may find by a patient would be some enteral feeding, typically nasogastric feeding, and that goes through this pump here. The next drawer down is syringes, needles, some flushes, saline, water, and they are for quick access, apologies, for flushing, checking cannulas are patent, checking lines are patent, and administering boluses of drugs in an emergency. Any other infusions or drugs delivered equipment would be retrieved from the equipment store and the drug cupboard. And in the bottom drawer are just the bionectors, taps, things that the nursing staff will use a lot of in a day, just as a store.
There are various levels of patient care that can be provided in an acute hospital setting. These range from level 0 to level 3, and we'll go through these briefly now. Critical care is collectively levels 2 and 3, but in some hospitals these will be split into intensive care, level 3, and high dependency care, level 2. For reference, we'll start with level 0 and work our way through to level 3. Level 0 care is any care that can be provided to a patient in an acute hospital bed setting. Anything above level 0 care is level 1. So level 1 care would include patients with a PCA, patients requiring anything more frequently than 4-hourly observations, somebody who has an epidural who's not in a critical care bed, and perhaps those requiring IV fluids or low levels of oxygen therapy. They may require support and advice from the critical care team, but they're not in a critical care bed. Level 2 patients are those who need single organ support, as long as that single organ support is not invasive ventilation or endotracheal intubation, which go hand in hand. Level 3 care is anybody requiring single organ support that is intubation and invasive ventilation, so advanced respiratory support, or anybody who's requiring 2 organ support, such as inotropes, vasopressors, and renal replacement therapy. The difference in nursing intensity between a high dependency level 2 area and intensive care level 3 area is that typically in a level 2 area you will have 1 nurse to 2 patients, whereas in ICU, critical care, you will get 1 nurse per patient. In the critical care areas, the patient is usually attached to continuous monitoring, which may be different to what you see in a level 0 or level 1 area. These include invasive and non-invasive cardiac monitoring, so blood pressure intermittently in a non-invasive cuff, invasive blood pressure monitoring via an arterial line, and continuous ECG monitoring, usually 3-lead ECG. Respiratory monitoring usually includes a saturation probe and respiratory rate monitoring. And if the patient is intubated, end-tidal CO2 monitoring. Other types of monitoring include urine output, intra-abdominal pressure, intracranial pressure, and pulmonary artery wedge pressure rarely. When considering admission of a patient to critical care, there are 2 key questions to address first. Number 1, does the patient require an increased level of care beyond what they can receive in the area they are in currently? And then secondly, do they have both a physiological derangement that they can recover from and the ability to recover from that? So what is their pre-morbid function, what are their comorbidities essentially, and is critical care going to give them the opportunity for a reversible cause to get better? Because there is nothing reversible to treat or an inability for them to cope with the current insult, then critical care may not be the best place for that patient. An escalation of care may not be the best trajectory. When considering whether a patient should go to level 2 or level 3 care if they are separate locations in the hospital in which you are working, it's more than simply what can each of those areas provide. For example, although a patient may currently only need single organ support in the form of a vasoactive or inotropic agent, if their trajectory is one of rapid deterioration, then admitting them directly to a level 3 area may reduce the chances of having to move them twice or intervene with a rapidly escalating situation in a high dependency environment. Of course, it's important to consider the patient's wishes when thinking about escalation of inpatient care. For example, patients with chronic diseases may have made decisions about how they want their care to progress in the case of a deterioration, and that may include not wanting to come to a high dependency area or an intensive care unit. An example of this would be an advance directive, or they may have had informal discussions with the family. Reasons for advanced airway support, i.e. intubation, are typically threefold. The first of these is because the patient has an obstructed airway, and the way to unobstruct the airway is to deliver an anaesthetic and insert a definitive airway. The second reason for endotracheal intubation is to protect the airway. So if the patient is unable to protect their airway on their own, which is often as a result of a decreased conscious level. The third indication for endotracheal intubation is to facilitate advanced respiratory support. For example, if you had an advanced pneumonia. There are various routes of definitive airway support. Those include an endotracheal tube through the mouth, an endotracheal tube through the nose, or a tracheostomy, which is also endotracheal but goes through the front of the neck. So indications for the respiratory organ support are, firstly, you can do it to support oxygenation, secondarily to support ventilation, and thirdly to intervene when you see a patient is beginning to fatigue or tire, so to reduce the work of breathing. For clarity, the definition of ventilation is the means by which you control CO2 clearance, and that is a product of your tidal volume and your respiratory rate. Common causes for hypoxia requiring increased respiratory support would be infection, pulmonary embolus, and pulmonary edema. Reasons for failure of the patient to clear their own CO2 and need ventilatory support are usually secondary to hypoventilation, so that would be decreased conscious level. Types of ventilatory support in critical care include non-invasive and invasive. So non-invasive ventilation would classically be via a mask, but can be via a hood. CPAP itself is not a form of ventilation, but is considered a form of respiratory support. If non-invasive ventilation is inadequate or not felt appropriate, then invasive ventilation is the advanced respiratory support that can only be supplied in a level 3 area. In a select group of patients who fail to be adequately oxygenated with invasive ventilation, extracorporeal life support or extracorporeal membrane oxygenation, also known as ECMO, may be an option. This is very similar to cardiac bypass and involves passing the patient's blood across a membrane on which the other side there is an oxygen supply and provides oxygenation of the blood outside of the patient. Cardiovascular support can be pharmacological or mechanical. Pharmacological cardiovascular support is not only in increasing blood pressure or cardiac output, but can also be used to decrease both of those. When we aim to increase cardiac output, that can be done by use of vasopressors, so an agent which increases vascular tone, inotropes, an agent which increases the contractility of the heart, or chronotropes, an agent which increases the rate at which the heart contracts. Mechanical cardiovascular support can be found in the form of a intra-aortic balloon pump. Other forms of cardiovascular support provided in critical care are antiarrhythmics, which can be used to control dysrhythmias in terms of both rate and rhythm, and pacemakers, which can be used to treat both brady and tachyarrhythmias. Neurological support in critical care can be provided by a number of measures. Sedation is perhaps the one that is most obvious. Sedative agents are used to facilitate other parts of intensive care therapies, both medical and nursing. When using sedation, usually the aim is to use as little as possible, but also to provide breaks in sedation so that we can assess neurological function. There is also good evidence that the less sedation used, the fewer the complications of stay within the critical care environment. Other forms of neurological support that we can provide in critical care include temperature management. That is both in terms of cooling and warming the patient where appropriate. To warm the patient, we may use invasive or non-invasive means. In non-invasive means would be a warming blanket, extra layers of clothing, increasing the room temperature, whereas invasive means would be using an extra corporeal circuit, which can be done via a renal replacement circuit or ECMO. Both of those can be used to also cool the patient, and non-invasive means of cooling the patient would be by using cool bags of fluid topically in areas like the armpit and the groins, or by putting a cool blanket around the patient which is supplied with cool water. Other forms of neurological support include seizure control. Usually this is by anti-seizure medication. Indications for renal replacement therapy would classically be hyperkalemia refractory to treatment, fluid overload, toxin clearance, or refractory acidemia. There are multiple forms of renal replacement therapy. Broadly, they can be split into intermittent or continuous. Usually in critical care we will start with continuous renal replacement therapy. The reasons for this are that 1, they can be run by our resident medical and nursing staff, and 2, they have less impact on cardiovascular stability in a patient cohort that is usually unwell, as opposed to intermittent hemodialysis or intermittent renal replacement therapy, which is more likely to cause cardiovascular instability because of greater fluid shifts. In terms of nutritional support in critical care, that is provided either enterally, parenterally, or as a combination of the above. So enteral support can be provided by supplementary drinks that the patient can take themselves, or via an nasogastric tube through which we can provide feed and other supplements. Parenteral support, it can be via either a peripheral vein or a central vein preferably. Most of what we do in intensive care is supportive and aimed at providing an opportunity for whatever pathology is going on to correct itself, so allow the patient to heal or to recover from whatever insult is happening. To that end, there is a focus on doing simple things well. Common complications from being in critical care are venous thromboembolism, hospital and critical care associated infections, and weakness from being in hospital and immobile for a period of time. The ways in which we reduce the risk of each of these are varied, but include multiple members from the multidisciplinary team. To increase mobility, we have both nursing and physiotherapy input. To reduce the risk of hospital-acquired and ventilator-associated infections, we again increase mobility, but are cognizant of antimicrobial stewardship. And in terms of reducing ICU-acquired weakness and frailty, we will use the minimum sedation load possible and try and liberate people from their sedation and their ventilators as soon as is practicable. Critical care admit some of the sickest patients in the hospital. Unfortunately, despite the multitude of organ support that we can provide, a number of these patients will not recover from their illness. When this is the case, the team will shift their approach towards an end-of-life pathway. The medical or nursing team are well practiced in this, and we pride ourselves in providing a holistic and supportive environment for both the patients and the families.